like to invite our second speaker from South Korea, Professor Minsun Jung, who is going to talk about the current political situation in Korea. No, I'm joking. From diagnosis to artificial intelligence in kidney transplantation pathology. Agency or Jung.
Yeah, thank you for the introduction and thank you for inviting me to this beautiful city. I'm Minsun Jung and I'm an assistant professor at Yonsei University in South Korea. I'm a GU pathologist and kidney pathologist, and I have a special interest in digital pathology, AI, or RNA, or spatial transcriptomics, something else. So now today I'm going to talk about kidney pathology and how to use digital pathology and AI in this field. So before I start, I want to know how many of you are kidney pathologists. Please raise your hand. 1, 2, 3, 4. Okay. So then, how many of you can diagnose kidney pathology? Even if you don't define yourself as a kidney pathologist, how many of you can diagnose kidney pathology? Okay.
In Vietnam, I am so sorry. In Vietnam, most of the pathologists are general pathologists, so they have to make diagnosis for everything, including kidney.
So actually, I omit the transplantation. I just want to summarize some basic concepts of the kidney pathology. I know many of you have learned these basic concepts, but please be back and feel free to revisit the basic concepts again, because they are very important to understand the kidney pathology. So the primary function of the kidney is to make urine. So kidney filters more than 1,700 liters of blood per day. So this is how the normal kidney looks. It measures 11 centimeter and the weight is between 120 and 170. And the kidney parenchyma is composed of the cortex and medulla. So in the cortex is a pretty interesting area because it contains glomerulus and tubules and blood vessels. Between tubules there is interstitium, but in normal kidney there is only a scarce of it, or we cannot identify interstitium easily. So in glomerulus, these are the basic cells and structures of glomerulus. We can identify them from the arteriole to the capillary blood comes, and inside the capillary there is the endothelial cells, and the mesangium anchors the capillary and keeps the structure, and within which there are mesangial cells, and all of the capillary wall, outside the capillary wall, there lies a visceral endothelial cells or podocytes, and the sac include the glomerulus is called glomus capsule, and the parietal endothelial cells are attached to the glomus capsule. So if you look closely into these structures, there are mesangial cells and endothelial cells, and there's also a black membrane which is called the basement membrane, and the podocytes, which looks like a octopus, override the basement membrane, so we can identify these mesangial and endothelial cells in light microscopy and electron microscopy. So the endothelial cells and basement membrane and podocytes, they make a very interesting structure of the basement of the capillary wall, and they filter the urine. So if they are damaged and normal urine is made, for example, if the podocyte is damaged, albumin will leak into the urine, so there will be proteinuria. Or if the basement membrane is damaged, RBCs leak into the urine, making hematuria. Also, for the location between the basement membrane and endothelial cells, we call it subendothelial layer or space. And between the basement membrane and epithelial cells, we call it subepithelial space. Podocytes covers the capillary wall very beautifully, and they are very closely packed to function as a filtration barrier. When we see the biopsy sample, and if we use a tissue microscope or even a magnifying glass, we can identify the glomeruli. Because most of the kidney disease, the glomeruli are the primary object for diagnosis. So we allocate the samples based on the glomeruli. For electron microscopy, one or two glomeruli are often enough, and for the remaining sample, most tissue is used for light microscopy, and the other for immunofluorescence. For most diseases in light microscopy, 8 to 10 glomeruli are usually enough, but for diseases involving focal lesions, it is that we have to evaluate many glomeruli. So if there are 25 glomeruli, we have more than 95% to detect the lesion. For transplant biopsy, we need to evaluate at least 7 glomeruli and 1 artery. Other than the number of glomeruli, the sample location is also important, because if the biopsy is only taken from the subcapsular area, the global glomerulosclerosis can be overrepresented because of a non-specific scarring due to aging or hypertension. For the FSGS, juxtamedullary cortex need to be evaluated, and for the BK virus nephropathy, medulla sample is also advised. Here's an example of light microscopy, HME, PAS. We can see glomerulus, tubules, and inflammatory cells. In silver and trichrome staining, I know there are many various stainings, and many hospitals use different staining, but these are the basic stainings for light microscopy. We can see global glomerulosclerosis and tubular atrophy, interstitial fibrosis. Using immunofluorescence, we can identify the deposition of immunoglobulin or complement. In using EM, we can closely look into the structure and if they are okay. These different techniques use need different methods. So for light microscopy, people often use tissue fixed in 10% neutral buffer formalin, and in the fluorescence, we use often fresh frozen sections, and electron microscopy tissues are fixed in EM fixative. In light microscopy, as I said, I use these 4 stains, and in the fluorescence, I stain chains and light chains for immunoglobulin and complements and others. So each light microscopic they has their own purpose. I said using H and E we can identify the basic structure or cells, or even viral inclusion or thrombus. Using PAS or silver, we can evaluate the basement membrane and for other structure. And trichrome or A4G, we can evaluate the fibrosis or thrombus or immune complex. Because H&E stains the basement membrane in cytoplasm in the same color, but while the PAS and silver stain highlight the basement membrane, because the basement membrane is very important indicator for the kidney pathology diagnosis, PAS is often preferred over H&E stain. So we can identify the patterns of kidney injury in the glomeruli, interstitial tubules, vessels. So glomeruli can show cell proliferation with or without leukocyte infiltration, or necrosis, sclerosis, GBM remodeling, immune deposit. Interstitium can show inflammation or fibrosis, tubules, necrosis, or cast or atrophy, vessels, sclerosis, pyelinosis, necrosis, or thrombus, or others. But when one component or some of these components have primary injury in them, there are many associated secondary changes follow. So we cannot tell them apart all the time. Through the biopsy, we can also determine the activity and chronicity of the lesions, and which can help to make a treatment decision. So let's look into the glomerular pattern. Compared to this normal tuft in glomerulus, there's a mesangial cell hypercellularity, and it shows the endothelial hypercellularity which obstructs or narrows the capillary lumen. It can be associated with leukocyte infiltration. If the inflammation is severe, it can rupture, and the parietal epithelial cells can be activated, and they proliferate, making crescents. These are hypocellularity in the glomerulus. So this is a normal glomerulus. It shows mesangial cell hypercellularity, leukocyte infiltration, and crescent. It also can show mesangial extension without definite hypercellularity. Here is GBM thickening or sclerosis. Sclerosis means increased extracellular matrix, often leading to obliteration of capillary lumen. It can be global, means it means the whole glomerulus, or only a portion of glomerulus which is segmented. So this is the basic description of the glomerular region. Within the tissue, if less than half of the glomeruli are in fact involved, we call it focal, or more than half we call diffuse. Within one glomerulus, if it involves a whole glomerulus, we call it global, or a portion, we call it segmental. Usually in IF, we can describe the signal along the capillary as a peripheral, or a signal in the mesangium as a mesangial. Let's move on to the tubular perforation. Tubules can show necrosis, but nowadays I think many people prefer to use just injury, because not all injury show necrosis. When tubules are injured, they often dilate as like this, and the epithelium is flat, gets flat and simplified with loss of brush border. They can also show vector degeneration or bleeding. Epithelial cells can slough off, and which make proteins leak into the urinary space, tubular lumen, making tubular casts. Yeah, now I move on to the immunofluorescence. Many glomerular diseases are associated with autoantibody, which means antibody reacts to glomerular antigen or some other antigen and make a immune complex in glomeruli, or only complement deposition without immune complex. So when there is a immune complex or complement deposition, we detect them using a immunofluorescence. So let's say the glomerular antigen are here. They are yellow, and the autoantibody to the antigens are blue here. So when we use a immunoglobulin reactive to the autoantibody, and if we find a FITC signal attached to the immunoglobulin, we can say there are autoantibody or immune complex. So if we see IgG, IF positive, like this signal, we can say there are IgG autoantibody here. And if we see IgA, IF signal, we can determine there is IgA autoantibody. And also for the location, if we see signals on the capillary wall, there are autoantibody or immune complex deposit in the capillary wall. Or if we see the signals in the mesangium, we can say the complex or immune deposit is located in the mesangium. Other than immune complex, the same goes with complement. So if we find positive signal in the C3 IF, we can say there are C3 complements deposited in the glomerular capillary wall or mesangium. So if we compare the glomerular structure in the IF, if we see like this pattern in IF, we can say they are in the mesangium. Or if we see like this pattern in IF, we can say they are along the capillary wall. So the basics of IF interpretation is, first we identify what kind of protein or what markers are we using. And if it is positive, we determine the location, if it is mesangial or capillary wall. If it is positive in the capillary, depending on the size of the positive signal, we determine if it is linear pattern or granular pattern. And for the most important thing is we have to correlate our IF interpretation with the LM or EM or clinical findings. So let's revisit this image, this previous image. If there are messenger IF, something happens here. Okay, if we find peripheral IF, something happens in subendothelial or intramembranous or subepithelial space. So what if there is something deposited in the subepithelial space? So if something is in the subepithelial space, podocytes, of course, they are primarily affected. And because of this subepithelial deposit, the glomerular membrane looks thick, and sometimes they can make a spike. Because podocytes have no or very little potential proliferation, in this case, there is no cellular proliferation or inflammation. And because podocytes are damaged, patients probably would have proteinuria. In mesangial deposit of the affected cells are mesangial cells, and which makes mesangial proliferation or mesangial hypercellularity. For subendothelial immune deposit, something is deposited in subendothelial space. So endothelial cells are affected, so they proliferate, and which lead to complement cascade activation. And because the subendothelial space is ultimately connected to the mesangial space, mesangial cells, they also ultimately proliferate. It makes like this lobular configuration of the glomerular structure. And when it gets severe, mesangial cells even infiltrate under the basement membrane, and then there becomes the new basement membrane forms over the mesangial interposition, which makes double control of the basement membrane or trantraxine. So for electron microscopy, the purpose is, or the usage of electron microscopy is to analyze the ultrastructure. So we can see food process of the podocytes. If they are damaged, the podocytes make a fusion, or which is called podocyte defacement. Another thing we can identify using electron microscopy is electron density deposit, which is an immune complex or complement deposit identified in IF. Or using EM, we can directly identify the status of GDM, thickening or thinning or other abnormality. So some of these podocytes are fused or effaced. The filtration barrier is lost. So for podocytopathy or primary podocyte disease, almost all podocytes show this effacement, but in secondary changing in podocyte or secondary damage to the podocyte, only a portion of podocyte look like this. We can also identify electron density deposit in the mesangium or subendothelial space or subepithelial space. Sometimes it can show hump-like huge deposit. Or we can identify thickening or thinning of the glomerular basement membrane, or the abnormal texture of the glomerular basement membrane, which include reticulation or lamination. It is important to integrate or incorporate all these findings to make diagnosis. So in LM, GBM looks very thick, and sometimes it looks spiked. And in IF, IgG is positive along the capillary. It is granular. Electron microscope shows a subepithelial deposit, so the diagnosis membranous nephropathy. Or in this case, the glomerulus shows a lobular configuration with increased cellularity, bubble control or tract sign of the basement membrane, IgG and C3 positive in the capillary, and subepithelial deposit. We call it MPGN. In this case, mesangial cells show hypercellularity, IgA positive in the mesangial area, and electron density positive in the mesangial area. So certainly, probably it is IgA nephropathy. So the primary role of kidney biopsy pathology is to make diagnosis and score the activity and chronicity of the disease to guide the treatment. So there are many scoring or classification guidelines in many different kidney disease or transplantation. They are too much to cover today, so maybe next time. But the kidney pathology is a challenging field. Diverse pathogen mechanisms ultimately produce a similar morphology change, so we cannot determine what is the cause always, and because it is relatively hard to obtain sample, to do kidney biopsy. Sometimes we cannot identify focal lesions all the time. And most of all kind of different diseases, when they are advanced enough, they make very similar morphology. So if a patient is in ESRD or very advanced kidney function test, the morphology looks very similar and very non-specific. Yeah, this ends the first primers of the kidney biopsy, and let's move on to the digital pathology. This is the one of the settings I use for diagnosis. I make all LM slides scan once they are made, and make them unloaded along with IF and EM images. And I use a dual monitor. Both are 4K UHD, but I am not sure the resolution is very important. I think 4K are good enough, and I also use a 3D mouse to navigate or zoom in and out or annotate something on the whole select image. So as previous speakers said, I can annotate this is global glomerular sclerosis, this is interstitial inflammation, and I can flag this area I want to look into again, or ask other people, ask other pathologists' opinion in this area. So this is quite comfortable for making consultation or education. And I can also measure the size or area like that. In this viewer, we can see there are 9 pulse-like images. 8 of them are light microscopy. One is IHC. And we can also see there are 16 more images in this pathology, in this patient. And if I click that, I can navigate the different types of IF and electron microscopes. In EM, I can also measure the thickness of GDN or maybe something other else. And one of the most beautiful things is the ubiquitous access to this program. So I can make diagnosis in my office, in the medical school building, as well as in the hospital, or in my room, or I hope not, but if I have to, I can access here in this room through the virtual machine. And as others said, I can provide feedbacks to the annotations made by others, so residents, fellows, or students. So it's a good tool for education. I think I have 7 more minutes, so I will briefly introduce my recent research using stain transfer model in kidney biopsy. Even though I didn't cover this transplantation pathology today, kidney transplantation pathology is one of a big topic in kidney pathology, and it consists of many regions or very complicated scoring system, which requires assessing all cells or structures of the glomerulus or the interstitium with how the inflammation and the injury or something other else. As I said, I use these 4 stains in every tissue. So for one tissue, and one stain, 2 stains for one item. So I make 8 light microscopy in one tissue. And I also make 2 or 3 sections in one glass slide. So for one case, I have to read 10 or 20, 15 or 25 sections per sample. Because I stain the sections sequentially in the serial sections. So it is very important to incorporate the information from different stains from one glomerulus. This process is very important in kidney biopsy. In H&E, we can see there are many cells in these glomerular loops in H&E. But when we also see the PAS, we can confident to say this is glomerulitis. Or the other example is thrombotic microangiopathy. In H&E, we can see some RBC fragments here, and in A4G, we can see some fibrin deposit, and in KS, we can see mesangial and enlarged endothelial cells and other else of thrombotic microangiopathy. But this process is often challenging. First, the morphology changes in different sections. So in the leftist, there is a small focus of RBC casts or RBC fragments. I don't know in this loop which is lost in other sections. So I cannot determine if this is a real thrombotic microangiopathy or not. And the second challenge is the need of a multitude of information in the same section, because in bank scoring used for transplantation, it requires interpreting inflammatory infiltrates and fibrosis, atrophy in the same section. So, maybe many different types of information in the same section, which is often hard. Other challenges include the special stains, because although H&E stain is usually automated and cheap and fast, special stains are usually more expensive, takes more time, or hard to maintain its quality. So I guess stain transfer could help this situation. I and my team used a, simply put, cyclic gain model to solve this problem. Cyclic gain is one of the common models used for style transferring. So I transfer from H&E style to PAS style. And it goes into back to the H&E style. And compare the original H&E and cycle back artificial H&E, and make them very similar. It's the basic concept of my model. And I also apply a Hugh loss to improve the confidence of the generated stains, the color of the generated stains. So these are the actual H&E input image, are the serial sections of actual special stains, and these are the generated special stains from the H&E. So if you compare these original PAS and generated PAS or other special stains, I think they are okay. So for many different compartments like tubules, artery, glomeruli, we apply this model. And as I said, I also applied Q loss to the baseline model, which slightly improved the accuracy and performance. And I also deployed this base model to data set from another hospital, which I think is quite reasonable. And after the stain transfer of the individual small patches, I stitched them together to make them like a real pose-like image, but they are not actual stains, but generated image. So using these artificial stains or stain transfer or virtual stains, in this set, it provides more in-depth information for individual slides, so it can make more accurate or concordant diagnosis. The second possible implication of this technique is we only stick to the H&E. We do only the H&E stains and use the stain transfer model to make a special stain. So it can give us a faster and cost-effective way to diagnose kidney pathology. Or third, I think it could be useful for consultation cases because usually I get a consultation kidney biopsy, only one H&E stain. In that case, the virtual stains can make the consultation much easier and make more confident diagnosis. Yeah, it concludes my presentation. Thank you for your attention.
Thank you, Dr. Jung. Any question? Quick question, maybe? Actually, we have a time spare for discussion at the end of the session, but do we have something to ask? Maybe a quick question from me. Thank you for sharing your research, your own research. Occasionally I see publications on use of AI in nephropathology. So what are the hot topics or what are the most promising applications of AI in nephropathology? Oh, you couldn't hear me? Okay. So the question is, what are the current most promising applications of AI in nephropathology? Sometimes I see publications coming out in American Journal of Pathology or some computational journals. So what is it? Let's see, like a current status of the apps.
So the application, you mean a commercialized application?
And not necessarily. Could be on the way to be commercial, like higher-end publications.
I think this stain transfer technique is one of the cutting-edge techniques used in high-end journals. I think because when a biopsy necessitates many stains and many sections, I think that's one reason. And the second is prediction of prognosis for the maybe for the rejection using AI we can predict the depth of the graft yeah, there are several high-end journals in that topic. I think, yeah.
Okay, thank you. Thank you very much.